Hello, everybody. Paula Nutting, your musculoskeletal specialist, and also this is part of our Supercharged Therapist membership portal. And today's interview, I'm very excited because we're going all the way to the north half of the planet. We're talking with Albert Quistorff, who is in the state of Washington. Is that correct, Hans?
Yeah, so that if you look at the top left corner of the state of Washington, you'll see that it shows indentations up there. And if you get a detailed map, you'll see that it's made up of dozens of peninsulas.
Okay.
And so I used to brag when I was in school that I lived on a peninsula to the 6th degree. I'm only to the 4th degree at the present time.
Yeah, yeah. And
there's
the world is changing so much that the peninsulas, who knows what they were like thousands of years ago and what will happen in another 1,000. So Hans has been in the industry for 20-something years?
25 years.
25 years?
20 years. For 20 years, I worked with a chiropractor as a chiropractic assistant and x-ray technician. And I also did a lot of the insurance report writing.
Okay. And it's really interesting because I'm going to get Hans to do another shoot at some stage on how we can actually best read radiology and radiography reports and what kind of impetus that means for massage therapists and remedial therapists out there. So stay tuned because that's going to be really exciting for the people on our Supercharged membership portal. So Hans, today we're going to talk about muscle sequencing. I'm really interested because I love, that's part of my thing is that I know that muscles have a certain order, and it's you don't hear very many therapists actually talk about it. So I'm very excited to hear what you've got to say and your years of knowledge behind it that can back up great efficacy and good results with your patients.
So let's take walking. When you walk, when you put your left leg forward, your left elbow comes back if you have good sequencing. And then as you reverse, put your right leg forward, the right elbow comes back. So that's all muscle sequencing. But of course, as therapists, we see people come in and they have paradoxical walking, that their arms don't swing in that sequence. They may have very odd sequences as how their arms and legs move.
Yes, yeah. Well, I quite often see them with the no arm movement, and that's very common.
Yes. So sometimes it's no arm movement, sometimes there's excessive hip movement, sometimes no hip movement. So yes, so the body has set up a different program, that the sequence is different for that person. And that is usually an evidence that their body is protecting some tissue that is been injured or is under repair, or that they're not able to cope with the pressure that's being put on it.
Okay, that makes sense.
So when you sprain your ankle or your knee, you're going to walk differently. Your body will set up a new program sequence in order to do that. But that alternate program almost always puts extra strain on some other part of the body.
Yeah, yeah. Would make
sense.
So
over the last 25 years then, I've built up a body of knowledge as to how the body tries to avoid these things. So I'm going to...
while Hans is finding the documentation
book here
for you guys.
Grab my show and tell book, okay, that this is from a radiology book for determining what the diagnosis should be.
Okay.
And it illustrates here that a disc injury that presses on the nerve doesn't cause any pain, but it sends an awareness signal that the body should not press anymore on that side of the disc, which then causes the person to have an antalgic lean off to the right.
Yes, yeah, absolutely. We get those.
Contrary, and that if the lesion is in a different position, even though it's quite close, but it's on the other side of the nerve, you have a left antalgic lean.
Yeah, yeah.
So the shoulders will be tilted. Okay.
Yeah, and we see that all the time as therapists, don't we? We see people that are standing that are off their normal alignment. And Hans has got one of those great postural markings at the back of his wall in his clinic. That's
So if I turn this a little bit, up.
So we used to learn with these with a plumb level, and then the alignment issue chart. So you could actually line your clients up.
There you go.
That's all right. You don't need to grab.
I should have done that. Okay. So the mirror is right there.
Yes.
But the mirror faces the chart on the other wall.
Okay, got it.
And so the client can sit here lining them, stand, lining themselves up with the string that is centered on the chart behind them. And so I can see it without the chart, but the client can see it. And so then it becomes obvious. And then we can help them puzzle it out.
Yeah, great idea.
So I had asked Paula if she would be the client today.
So I'm a little bit worried that I will be completely out of whack, because we all are. The older we are, the worse we get.
So over the last couple of weeks, I've watched her seated and interviewing people or conducting a meeting for about more than 4 hours. I think I have watched you. And so I see what your posture pattern is.
Okay.
And when you get tired sitting, your shoulders tilt off to the left.
Okay.
Okay. Yes. And the reason for that is probably your right ischium is tired of carrying the weight.
Okay, that would make sense.
You want to put the weight over on the left ischium for a while.
Yeah.
So you apparently have a very strong ability for your spine to center over the right hip socket.
Yes, indeed.
So this is part of the walking sequence, and that's the psoas minor.
Okay. All right.
What is the function of the psoas minor? The charts and books and so on will tell you what the action is. But the function, what the normal day-to-day function of that pair of muscles is to line the spine up over the weight-bearing leg, or in sitting case, over the ischium.
Yeah. Okay. Yeah, because we don't talk about function, we talk about actions, origins, insertions, and actions, don't we? So.
Right. So then as you switch from walking, and you're walking from the weight on one leg over to the other leg, that the muscle that's in concentric contraction is going to go into eccentric contraction, and the one that's been in eccentric contraction is going to go into concentric contraction and pull the spine over so it lines up over the other hip socket or ischium if you're sitting.
Yeah, Wow. So we're talking about the psoas group doing that, the eccentric and concentric contractions, or we're talking about more than that. We're talking about like all the way through gait. So all of the drivers that move the hips.
So in other words, it has a capacity to pull the spine that the psoas minor is attached to the front of the bodies of the 12th thoracic lumbar and of thoracic vertebrae and the first lumbar vertebrae.
Okay.
And so it doesn't cause rotation like the psoas does that's attached to the transverse processes, but it pulls the spine forward as the trail guide says it helps with maintaining lordosis.
Okay.
But unilaterally, it's going to hold the spine anterior and lateral, which moves it over the hip sockets attached directly above the hip socket.
Yeah. Yeah. Wow. And that makes total sense. And yet my history that you won't know is that 5 years ago, I had a total hip replacement on my left hip. So I had pathologies on the left, which has obviously meant that I've been dragging over to the right. My right fatigues and then down I
So
go.
that's where then your past trauma history means that your body is inhibiting the left psoas minor.
Okay. So how do I wake that up?
So the thing is, you need to be aware then that your body is going to have to get the center of gravity over the left ischium when you're sitting there in order to get relief. So what you do is bend your spine to the left, which means that I'm watching you there and you're sitting there all of a sudden, I'm exaggerating, but you are facilitated in that your head stays straight up and down. So this was another thing that came up in training as a chiropractic assistant, that the assistant for much of this group would be responsible when someone came into the chiropractic office to take a look and say, is that person facilitated? Do they able to compensate for any discrepancy that they have in their postural lean?
Yeah, yeah.
And so if the person comes in and they're off to one side, okay, but the head straight up and down, they're compensated. But if this head is off to the side, as well as the shoulder down, they're non-compensated.
Yep. Yeah.
Okay.
Yeah.
And then if you get them to stand up straight and the head's going off to the side, that means they're non-compensated. They're not able to correct again.
Yeah.
And you can see how with someone being chronically one shoulder down, the neck is going to be chronically tightened. The programming is going to tend to not cancel when you bring the shoulders up straight.
Yeah. And that brings us to the Lovett phenomenon, doesn't it? So cervical and lumbar.
Right. So that's where our spine is set up with the reactor relationship.
Yeah.
So the chart that you sent out in the super therapist group, okay, was a reactor relationship.
Yes, with the sphenoid bone, and then it went down to all the way through the pelvis.
So in my show and tell book, okay, I have from Paul St. John's classes, the reactor relationship with his revision. So an interesting factor that he put in is that the top three vertebrae and the bottom three vertebrae.
Yes.
Actually, you could
C1,
put 4 because the pelvis and the skull work with that. that allows you to keep looking straight ahead with this motion that we started out with walking, with your arms going forward on one side and back on the other, and the legs. It allows, with that difference, to keep looking straight ahead.
Yeah, yeah.
So understanding the sequence that the body uses and being able to see and feel the difference with someone who has a protective pattern for the injury they have is one of the easiest ways that we have to trace down what the source of the problem is.
Okay. Yep. And can you unpack that a little bit more for the therapists that are listening? Because I know a lot of people someone comes in with neck pain, so they spend an hour treating the neck. And we know that experienced therapists know that that's not the way to get a good outcome.
Right. So we have the craniosacral chart here behind me. And so many of the things that are taught by Upledger for craniosacral are very helpful in being able to actually feel the sequencing that the body is doing.
Okay.
So basically, I call what I do interactive craniosacral, in that instead of my just sitting there and waiting for the body to move, I ask the client to move.
Okay. Yep.
So I love this chart because apparently someone took an X-ray and used it as the foundation for making their drawing.
You can see the pelvic bones and the spine.
Right. So let's look at those pelvic bones. Are these two holes the same size?
They don't look at the one on the left looks more circular and straight on, where the other one looks like oblique.
But now, when you know the anatomy, they are the same size, right?
Yeah.
So the X-ray is a shadow.
Yes.
The camera is behind the person. Some people get it mixed up. There's a light in front and a camera behind. A camera means a chamber. And so there's a film in the chamber that normal light can't reach, but X-rays can. So it makes that shadow. So you have a projection.
Yes.
And so then if you look more carefully, you have one alien here that is tilted inward and the other one is tilted outward.
Yes.
The openings are actually in back. So the one that's tilted outward makes the hole look smaller.
Yes,
and
it's moved in that
makes it look larger.
Yeah.
So that was part of my assignment, is when I would be transferring the information of the X-ray onto the client's chart, we would have a line drawing and I would put a little circle and a big circle, and the doctor would know what the distortion pattern of that client was.
Okay. That's great. So you were giving him some diagnostic evaluation from the films.
So I don't make the diagnosis, I just make the measurements. But of course, I understand what the record gives. So as you mentioned, in the future, then we can go into more detail on another subject as to how, if you have a client comes in and they say, I have this disc that has my radiology on it, you can actually put it in your computer, and most of the time there'll be a program that's on the disc that will allow it come up and for you to see the X-rays.
Yes, yeah. Well, the one that you sent me, I needed to get access, so, and that makes sense because it's medical records and there's a privacy issue. But we can certainly grab some of the actual rather than seeing the images, we can get some of the reports and then maybe some films. So I think I might have some films around too.
Right. So getting back to our client here, Paula,
Oh,
that so she's then in our conversation here then that you would make before you start with your client, brought up that she's had these past surgeries.
Mhm.
Okay. Now, how could we help Paula come up with a personal program that would allow her to perhaps overcome the programming that she's built up in protection to be able to get the psoas minor to work both ways?
yes. Yes, please.
Okay, so Paula, you are experienced enough, you would have a good idea where is the center of gravity.
Well, it should be when we're looking at below the umbilicus, around that.
Right, so basically, somewhere's in the region between T12 and L1 and the navel, okay, is the center of gravity. So you can see how that psoas minor is in the exact place to be able to shift the center of gravity from one side to the other.
Yeah, yeah.
Okay. So would you like to stand up for a moment then, Paula?
I will. I'll get myself far enough back so we can still see me.
Okay. So put a finger in your navel or umbilicus. Okay. Very good. Okay. So try to get yourself with the weight on your right foot. Okay. So if you look down, you'll see that your finger is pretty much in line with the groin on the right side.
Yes. Yep.
Okay. So now you want to shift your weight to the left foot, and your finger should move over and line up with the left groin.
Yeah.
And if you want to check, you can use the other hand and check in back for T12 and L1 and see if it's actually shifting there.
Probably not as cleverly. I think this one is far better over here. I'm dropping over much better than this side, but it's short.
Yes. So this is where you have a dominant program because of your past history of lining up your spine over the right leg because that is the best weight bearing.
Yes.
Okay. But for the sake of the rest of your body, you want to try to get your body more confident to move the spine over the left hip to know that it's not going to hurt, or if it does, find out what you can do to correct it.
Wow. Okay. So that's a simple.
So the residual programming that we have from past injuries, you see, is altered the sequence of how we move.
Yes. Yeah.
So this is where understanding muscle sequencing is very helpful for us to assist our clients.
That's really interesting because it doesn't really want to go there at all. I'm hoping.
You're programmed to protect something, okay, and not use the psoas minor as strongly as you do on the left as the right.
So how do is there homework that we can?
That's your homework.
Well, that's a great homework. That's great homework because
that's your homework because now you understand what you're doing and how to notice how strongly that programming is.
Terrific. That's great. I think you've frozen for a half moment, Hans. So if you go down to your video and you click the stop video and start video again, will get you. I'm just going to see if I can stop and start myself. We have sorry guys, we have a small hiccup with some of the connections between North America and Australia. So as soon as Hans gets back on here, we'll keep chatting. But just to recap, that's a really cool thing to know, that we want to find our center of gravity and work from a space where we know that if you're going to put your finger at your belly button when you stand on one leg, that your belly button and spine, the natural feeling of that psoas minor is going to pull you across to that hip bone. So if you've got lower back pain and very unstable, even sitting and going from one ischium to the other ischium might be a task for someone who's got discal injury. So if they're really inflamed and don't want to have much movement because of fear, we can start in a seated position and then get them up into a standing position and then work that through. So we're going to progressively overload. So it might be standing on one spot, just weight bearing. And then it might be standing on one spot with slightly lifting the heel off the floor of the non-weight bearing leg. And then we will progress that. But I'm sure that Hans, when he gets back, will be able to unpack that a little bit better for us. The other thing is that I'm going to put in some links to give you a heads up for when we're actually going to be doing that tutorial. The tute will be, here he comes now, the tute will be all about how to read the radiography reports. And once we've read the radiography reports, what we then do with them. Hey, back again, Hans, good to see you. I was just filling them in on some of those homework techniques that their patients can do or clients can do. But I'm going to let you keep going with we've probably got about another 10 or 15 minutes.
Right, yeah, so that so to help people connect the dots, I've started to use our computers as an illustration. The people doing computer programming are, of course, are humans.
Yeah.
But they run into the same problem that we humans do in programming our brains to operate our bodies well.
Yeah.
And that is that they wind up with a conflict, okay, which sometimes will give you a blue screen and you have to reboot your computer. In this case, it was my modem,
Yeah.
which cut out because of someone making an incoming call, and I haven't been able to solve that problem that it cuts out the modem with an incoming call. So there's a conflict there. So likewise, when we have many conflicts of trying to guard our body, someone comes in and they've been diagnosed with fibromyalgia.
Okay, yeah.
And that's a syndrome that is determined when 11 out of 18 different common pain points are too tender. Okay, that just a light touch, even a garment touching it, can set off a pain reaction.
Yes.
So that overloads the brain. Just like the computer, or in the case of our incident today, the modem gets overloaded and turns off and has to reboot. So our brains suffer the same thing. They're no longer able to cope with automatically running all of these alternative programs.
Okay, yep.
And so then they're not able to even resequence the problems they have without guidance. So I consider myself a coach.
Yeah.
When a client comes to see me, I'm not going to cure them. I'm not going to heal them.
No, we're not.
I'm going to coach you to understand your problem and be able to retrain yourself to do the best you can under your current circumstances.
Yeah, perfect. And I'm trying to
So
do that
you
right.
feel that I've done that for you today?
Yep. And I'm already doing my homework. I'm already trying to mindfully get my belly button over to one side and feel that the weight, I can weight bear just on the ischium.
Right. So that if there is a specific residual problem that, needs to be dealt with, as you do your homework, it may become obvious, because then it will be sore because you're now putting the load on it that you've been trying to avoid.
Yep. How interesting. So what's your thoughts? At what stage can we add just simple things like single leg balance?
Could you repeat that?
I was just saying, what's your thoughts on how quickly we can introduce single leg balance to our clients? So if someone's got issues with weight bearing, I always try to give balance exercises quite quickly in a routine.
Right. So here's a principle that was in Lawrence H. Jones' Strain Counter Strain.
Yep.
He says, if a simple stretch in a position of ideal comfort is enough to stop a chronic dysfunction, then a simple painful effort is sufficient to restore the dysfunction. So exercising this dysfunction with pain will restore the rheumatic pain in your joints.
Okay. So don't do stuff that hurts.
That's why that one time I was watching a video from the man that started the Czech Institute, which is for body trainers. And so he summarized what I just read there by saying, if it's not fun, it's not functional.
Oh, wow. That's a great term. If it's not fun.
Well, if you assign someone's homework, make sure you include that.
Yeah.
If this is uncomfortable, if it doesn't feel like it's helping you, then you don't do it. You find one of the other things we've talked about and try doing that, because you'll just make it worse.
Yeah.
And this was the problem I had with many clients that would be sent for physical therapy. The physical therapist would give them an appropriate exercise if they were capable of it.
Yes.
But they weren't capable of it.
No, that's right. Start small and then progressively overload. Don't.
Right.
And the no pain, no gain is not.
Right.
Yeah.
So the way that you can help a client quickly get to where they can stand on one leg is to help them be able to sit on one ischium. Okay, that's much lighter load.
Yeah, perfect.
Okay. So many of my clients, I have them lay on their bed with one of those large exercise balls under their legs, and then practice the appropriate movement that they need to strengthen while they're not under the load of gravity.
Yeah, perfect. Perfect. That's, yeah. Swiss balls or fit balls, they're used the right way, they're amazing. They help so much. No, that's perfect. So if you haven't got a fit ball, guys, get yourself a fit ball, but don't get the really, really big ones. You normally try to get one that's going to be about the same. Your bottom, when you sit on it, should be just higher than where your knee angle is. So they'll come in 45, 55 centimeters.
For most people then, unless they're a very tall, slender person, that the largest beach ball that they sell, okay, will often be of adequate size. And because they're laying on the back, the exact size is not as critical as if you're sitting on it.
Mm. Okay, well, that's good to know. And that way,
Right.
beach ball is a lot cheaper than going to get a fit ball.
Right.
Well,
Yeah, it's, basically $3 versus 30.
yeah, and I agree. It doesn't have to be too, but it should be it shouldn't have to be too high that if you're lying in supine with your hips and knees at 90, your knees shouldn't be too much more than about 100, 110 max. So, yeah.
Right. So you can use the ball also as a therapy band. You
Oh,
put the heels on the ball, okay? And you can stretch the ball by pushing with one and pulling with the other, and you're activating the muscles that you lift your legs with.
yep. All right. So lying supine and pushing and pulling.
Right. So that restores the programming for your psoas. And if you engage your elbows as you would if you're walking, then your latissimus dorsi is attached right behind the psoas minor.
Okay, so that's where that.
And so that activates the connection.
All right.
Okay.
So just for people who are going, hang on, how's this going? So they're going to lie on their back with their knees bent and their feet on the ball.
So yeah, you start with your knees over the ball, rock from side to side by pushing your elbows. So you build up the sequence. Then you finish with being able to sequence down to your feet by putting the heels on the ball.
Okay.
And then if you practice pushing and pulling, so you're imitating being able to stand on one and lift the other. And then finally, especially if you're going to go skiing, you start making the ball go in a figure 8.
Okay. Yeah.
So the knees go one way and the heels go the other.
Yep.
And you can circle the ball either direction or make it go in a figure 8. If you can do a figure 8, then you know you have good sequencing.
Yeah. Wow. Well, that's fantastic. That's really cool. So probably what I might like us to do is get a couple of maybe not now, but I'll get a small video of you doing that, because I actually used to have a fit ball around, and my clinic is too small.
That's one of the projects that I have been putting off for the longest time is getting a video of that so that we can share it.
Yeah. All right. Well, between you and I, we'll get that. We'll make sure that happens, because a lot of therapists are more visual or kinesthetic, so it's better for them to be able to actually see and feel it versus just hear it. So we'll make that happen. We'll definitely make that happen.
That's why I asked you to be my model today. Okay. So people got to actually see what we're talking about.
Yeah, amazing. There's such great steps forward for people just to understand that the whole concept of muscle sequencing. So please, when you're in your clinic, if someone comes in with neck pain, don't just be thinking neck, think outside the scope. And conversely, if someone comes in with lower back pain, don't spend your whole time bashing into a QL.
So with the neck is going to go into the breathing.
Yep.
Okay. And the breathing is going to go into the diaphragm. And where is the lowest attachment of the diaphragm?
Yeah, we have that wraith that comes all the way around to the hip flexors, to your psoas.
Right. Well, in the center, you have an attachment that is intertwined with the psoas minor.
Exactly. And then we look at pelvic floor.
So this is where, when you hold your shoulders back and breathe deep with your diaphragm, it will automatically be pulling on the front of the spine and transferring the force to the pubic bone. Okay. And you will then be able to transfer the force of your breathing clear down to the floor.
Yeah.
So when therapists talk about grounding, every action that we make has to go to the ground.
Yes.
The
Yeah.
law of equal and opposite reactions,
Mhm.
that we have to try to move the earth in order to move ourselves.
Okay.
So that's one of the strongest groundings is we have our levator scapula or our trapezius connecting down through the latissimus dorsi to the psoas minor, to the pelvis, and then our body will transfer the weight appropriately depending on where we are in our activity to the ground.
Yeah, yeah, and that brings in Maya's deep front line. Unfortunately, we're going to have to wrap it up because I've actually got my first patient in 5 minutes' time for the day, and we started.
Very good.
It's too late.
So,
but
tell everyone that I'm going to be available for at least the next 3 months to keep adding to the insights that this group has.
That'd be fantastic. So what I'm going to do is I'm going to make sure that this goes to my girl, and she's going to top and tail it. We're going to get it up on the website ASAP. But Hans, thank you so much for your pearls of wisdom, because they are incredible gifts. And I will talk to you again very soon in the portal and also here.
Okay.
Thank you, Hans.